So in I-SPY 2, we'll have a third trial, I-SPY 3, that we'll still need to sort of plan and start. So in 10 years' time, I think those tests will be available.
And the monitoring requires invasive biopsy, or is it pretty minimally invasive?
And one invasive biopsy before treatment, and then imaging, which you will hear later.
Potentially only imaging, because we convince the pathologists that we can replace them with an MRI.
Sure, yeah.
I love one more question.
Well, now a print requires fresh tissue or fresh frozen tissue, and most of the community cancer centers are not going to do that. They don't have the freezers. They don't want to set up for that. I find that very frustrating, and wondering why we just can't make them provide that.
Only requires RNA retention. It only requires RNA.
Yeah, you don't need to freeze it actually, but you need to capture fresh tissue. And I agree with you. I think if this could all be done in a perfect way on formalin fixed paraffin embedded material, I think I would be happy to start all that right away. I think the Oncotype DX recurrence score, which is a prognostic test, is doable on paraffin embedded tissue, but I think if you start to want to do more tests on one tissue sample, I've not yet seen that can be done on paraffin, and so then you have many more options on fresh tissue.
Right.
We're working on it. We're working, the Athena project, we're trying to work on a better approach with the universal fix-it. We'll hear more about that.
I think it started like 10 years ago when estrogen receptor assessment was done by ligand binding assay.
Right.
Everybody was freezing, and now all of a sudden it's...
They gave all their freezers away.
Well, that's not, no, I think people don't like change. But we're going to change all that. No problem. We're going to like change everything. So, I'm going to try and go briefly. I'm going to skip over some slides because I want to make sure everyone has a chance to talk and we have more discussion. So, if you just think about the problem, and we're on the opposite end of the spectrum. In the Netherlands, we treat everyone. But the problem is people are still dying at about this, we've made some progress, but not that much. We still have 200,000 women being diagnosed every year, so that's really increased a lot. But it used to be 50,000 women a year were dying, now 45,000 women a year are dying. That's a problem. We still have, so going back to how biomarkers help, you've got to go back to what are the central problems. So in spite of screening, we still have this rate of locally advanced cancer that hasn't changed very much, so what's the problem there? And these women who present with these larger tumors are often younger, at the highest risk to die. Is that something we can fix with better screening, more screening, and how can biomarkers kind of inform in that? So I think part of the problem is that all breast cancer is not the same. We call it breast cancer, but it's not, right? So that some disease is fairly indolent. You just saw that Laura was able to use these molecular profiles to show some fairly indolent and may never come to clinical attention in their lifetime. And the great thing about the NKI studies is that in the absence of all adjuvant treatment, that's really important. And that's very different from Oncotype, and I'm just going to show you an example of that, which is another molecular test. And the more molecular tests that are used, the more people are going to be comfortable with it and thinking about it. But that was really a test designed for people, how likely are they going to fail if they have tamoxifen. It's not treatment alone. So it's really important. People in the United States are very geared towards making sure everyone gets treatment, but not everyone needs treatment. Some diseases are going to be more aggressive, like the NKI 70 gene test or the Oncotype high risk. But one thing I think Oncotype really helped make popular is this idea that there are some patients you can have risk. You can have even an intermediate risk on the Oncotype score, for example, where this would be in the 28, and you could say maybe this is the way the Oncotype score gets reported out. This is about 21 genes, 5 of which are housekeeping genes, and it's on a paraffin section. And so you could be, they came up with this low, medium, and high risk group. And here's, I'll show you looking at how people responded to therapy. So you can imagine if you had something like this, where you come over, you still have an 18% chance of recurring. But if you look at standard therapy, one of the studies they showed, and again, people say, oh, this is all cover, so it doesn't mean so no one believes this data, even though that's the data. The people with the highest risk have a good response to therapy. The people with the lowest risk don't have much risk, don't have much response to therapy. It doesn't change in absolute terms, but neither do these intermediate people. So you can have risk, but maybe your risk is not affected by chemotherapy. Or maybe it's not affected by the chemotherapy we have without something else. So it's just, I think, important that there's plenty of room for improvement, And there's a lot of clinical problems. And biomarkers can help us solve those problems. So we need to think about who needs less treatment. Laura just talked about that. I'm going to give you a specific example of how I think we can drive this even further. And who needs more tailored treatment? Clearly, the people who are dying in spite of having optimal therapy need better treatment or more tailored treatment. So there's a potential problem with screening. People say, oh, if we could just screen early, we just screen more. The diagnostic people come to me, oh, I can find the cancer when it's a cell big. It's, please, don't. No, I don't want to know about that. What I want to know about who's destined to have the cancers that are going to progress and kill people. So here's some hypothetical screening scenarios where you might say, let's just say you introduce a screening test and you get initially an increase in your overall cancer rate, and then that comes down and doesn't change. But what happens is this is your early cancer, and this is your late cancer, that your early cancers go up, and your late cancers go down. The worst case scenario is your screen test, you find more cancers, and your early cancers go up, but your late cancers don't change though, or the ones that have spread to the regional ones don't change. That's not so great. And the intermediate one is it goes up a little bit, your earlier cancers go up, and you have a little bit of drop here. This is somewhere in between. If you use, though, as your metric, what fraction, after screening, what fraction of cancers now appear as early stage cancers, you get the exact same answer from each one of these scenarios. That's a problem. So that's not the right metric. And if you actually look at the United States, you know, this is what's happened. So here are your late stage cancers, and here are your early stage cancers, and here's your overall cancer rate. This looks very much like the intermediate scenario, at best. But as a fraction, your early stage cancers, if you said, oh wow, look how much progress we're making, we're finding most cancers in early stage. But that's not helping you if your late stage or your regional cancers haven't gone down very much. This is sort of what's fueling this whole mammography, you know, hysteria, right? Is that people don't want to accept that. And what I say is, here's the problem in the United States, is that if you really looked at localized cancers as a fraction of the instance, so you looked at overall rates, the problem is that you haven't really changed this that much, and you're not going to make as much of a difference. In the Netherlands, we looked at the same thing. We looked at the data. Laura had her people look at it. Again, you've got, with the screening era, and there they screen actually more than we do. They have, what, 85% of their population screened. And when they do something, you know, everyone gets screened, it all gets paid for, it's really well organized, you know, much more so. It's not like it's haphazard. You have to say, if we just did more screening, is that going to solve the answer, solve the problem? Well, probably not. And the reason why it's not going to solve the problem is you don't want to find these cancers. And you may not even want to find these cancers. They're kind of growing really slowly. You imagine this is time, and here are your screening intervals. These are the cancers that you want to find. In any screening situation, colon cancer, cervical cancer, moderate to slow-growing cancers are the ones where you do the best with screening. Because it's not like some terrible cancer, what Laura said, was even small cancer can be very bad. The cat's out of the bag at the time you find it. So even if you find it here, it's still got bad biology. You would make a mistake by not treating this person with chemotherapy or more aggressive because it's bad biology. That there's a component of biology that trumps screening. And so that people have to get into their brain that this notion that early detection is the answer. Just finding it early will solve everything. It's not true. And I think that we have enough data. I firmly believe that we have enough data to show that. I would say that certainly not everyone agrees with me. I think that that's probably fair to say. However, so let me show you some data that Laura and I have. And oh, and by the way, we also know that different populations get different kinds of cancers. African Americans, for example, and Hispanic women are much more likely to get triple-negative cancers. This is data from the Women's Health Initiative. Warren Jablonski's that presented. So, all right, so we talked about this. So we, my colleague Ian Thompson at the University of Texas San Antonio, comparing breast and prostate cancer, we called for this notion of trying to find indolent lesions of epithelial